Hi, my name's Ewen Griffiths. I'm a consultant of the GI surgeon from Birmingham, UK. It's a great pleasure to be here today to discuss preoperative COVID testing of the esophageal patient, which tests and when. I have some disclosures, but none of them are particularly relevant to this presentation. Patient COVID testing is absolutely vital for all operations, but particularly esophageal cancer surgery, as it affects patients who are elderly with comorbidities, and particularly men. I'm going to show you some data that shows that patients who develop COVID-19 after surgery have a very high risk of post-operative morbidity and mortality. There's a variety of methods for COVID testing or risk mitigation, and these include PCR swabbing, CT of the chest, and patient isolation. And then I'll finalize my talk with looking at some esophageal data in the COVID era. So my first statement is that patients who get COVID-19 infection after surgery have quite a bad outcome. And this is data from the COVID surge cohort study. This was published in the Lancet in May last year. This was a large multi-center international cohort study looking at 30-day mortality of patients after surgery who developed COVID-19. And 1,128 patients were included. The overall mortality was astounding at 23.8%. And I've highlighted the elective column. These were patients who, admittedly, only 280 patients who had elective surgery. And the mortality was still high at 18.9%. If they had a preoperative diagnosis, the mortality was 9.1%. If they had a postoperative diagnosis, the mortality was 20.4%. Looking at the data, the mortality changed. It was much worse in men, much worse in those over 70, and much worse than those having major surgery, particularly cancer surgery. And this highlights we need to do as much as we can to prevent operating on patients who have asymptomatic COVID-19 infection. Before I move on to talk about preoperative testing, I just want to include some data from the COVID surge cancer study. And this clearly shows that ideally cancer surgery should be performed in a COVID-free surgical environment. This study was published in the Journal of Clinical Oncology last year, and they looked again using a multi-center cohort study methodology. They compared hospital environments, those that had a completely clean COVID environment with clean wards, clean theatres, clean ICU, to those that had no defined pathway and had mixed COVID patients, either in theatre, on the wards, or in ICU. And they showed quite nicely that there was much better outcomes with patients treated in a completely COVID clean surgical unit. The rates of mortality, the rates of pulmonary complications were statistically much less. Moving on to screening practices, this is a paper by Al-Massar et al., published in the Annals of Surgical Oncology very recently. They looked at the different centres throughout the world to see what they were doing, and they had variability in preoperative isolation practices. Most were using PCR antigen testing. Some were using CT of the chest to rule out COVID infection. And again, there was differences in post-operative isolation and also the way the staff were tested and screened as well. So what is the best pathway for patients? Well, I'm going to show you some data that screening should be with preoperative PCR testing. And I'll show you some data that thoracic CT is not particularly recommended, as it has a very low additional yield. And this is data from the Dutch SCOUT study, published in the Annals of Surgery in December last year. They looked at the yield of screening for COVID-19 in asymptomatic patients having either elective or emergency surgery, and they really compared CT chest with PCR testing. The SCOUT study was a multi-center observational study, 3 academic centers and 11 non-academic hospitals in the Netherlands. It was done in the early phases of the first wave of the COVID pandemic, and they looked at 2,093 asymptomatic patients. 1,224 were screened with a combination of CT chest and PCR, and 869 by chest CT only. They used the CORADS classification system, which was developed for grading the CT of the chest for typical findings of COVID-19 infection. These include glass ground opacities, peripheral and basal distribution, vascular thickening, and consolidations, moving to atypical findings and very atypical findings. And the CT chest could be graded from 1 to 5. PCR positivity was given a classification of 6. And this is just some CT features. CORADS 2 is unlikely to be due to COVID-19. CORADS 4, the suspicion is very high. But what's come out of this study is that these features are non-specific and could be due to other things, such as other respiratory diseases or changes related to smoking, etc. And the results showed that combined testing with CT and PCR had a yield of 1.5%. COVID PCR confirmed infection in 1.1% of patients, so that CT chest had an incremental yield of about 0.4%. Although the findings were that these could be due to false positive results, as actually none of these patients developed COVID-19 symptoms or infection later on. And there was no post-operative symptomatic COVID-19 infections were seen in patients who had a negative PCR testing. In contrast, there was 3 patients who underwent CT screening with negative results who developed post-operative symptomatic COVID-19 infections, suggesting that these infections were actually missed by CT. And I think this gives good evidence that we should abandon CT screening and focus on PCR testing. I'm going to move on now to look at some esophagectomy specific studies in the COVID era. The first paper is by Dolan et al., looking at esophagectomy for esophageal cancer in the first wave of the COVID pandemic, just published recently in the seminars of thoracic and cardiovascular surgery. They compared 96 patients treated pre-COVID to 37 in the COVID-19 first wave. They showed no delay to surgery. The overall complication rate, there was no statistical difference, but slightly lower in the COVID-19 group, suggesting perhaps they were selecting patients better. The 90-day mortality, there was no difference in that. No patients developed COVID-19 after surgery. And I just want to show what their screening tests were, their preoperative directives. In terms of the patients, they had to have a negative COVID-19 PCR 72 hours before surgery. They were directed to self-quarantine from the time of that test until they came in the hospital. And post-operatively, they were tested every 3 days for COVID-19 during the inpatient stay. Each patient had a private room and no visitors were allowed. The hospital staff had daily symptom assessment and were required to wear masks at work. But I'm not aware that they were actually tested with PCR or lateral flow tests during the first wave of the pandemic. A similar study from Newcastle, UK, they had a different, slightly different pathway. They advised that patients should self-isolate for 14 days before surgery. They screened with PCR testing 48 hours preoperatively. Patients planned for esophagectomy had a CT of the chest, but they analysed their data for 100 patients and then decided to abandon this as it provided no extra yield. And also the UK guidance from the Royal College of Radiologists and Surgeons abandoned that practice also. Interestingly, 2 patients developed COVID-19 within a month of surgery. Perhaps this was picked up after discharge or during their hospital stay. One spent 4 weeks in critical care due to respiratory complications. Luckily, both recovered. Another bigger study, multi-center, from Borgstein et al., published in the Annals of Surgical Oncology. They looked at data from 4 European tertiary centres in the Netherlands, Germany, Belgium, and Sweden. They compared a cohort from the first wave of the COVID era and compared that to a control group, slightly larger, of the pre-COVID. Again, they showed no difference in respiratory failure requiring mechanical ventilation. There's no difference in pulmonary complications, and there's no difference between overall post-operative morbidity and mortality. We're all comparable between the cohorts. Their schedule was history taking for fever, temperatures, coughs, and viral symptoms. They tested patients with reverse transcriptase PCR. Preoperatively was done in all centres, and they found that no patients developed COVID-19 pre or post-operatively. So in conclusion, we have data to suggest that post-operative COVID infection is a devastating complication. We have data to suggest that major cancer surgery such as esophagectomy should be performed in a COVID-free environment. I would suggest the best practice is for PCR testing 72 hours before surgery, and patient isolation is important. CT of the chest has limited additional yield and shouldn't be used. And we really need to modify our pathways and maximize prevention strategies to make sure we get the best outcomes for our patients. Thank you for allowing me to talk. If you have any questions, I'm very happy to be contacted by email, and I'll look forward to the rest of the meeting. Thank you very much.